Today, in our next installment of the CGA podcast series on FAP-related neoplasia, we're going to be moving outside of the luminal GI tract to discuss desmoid fibromatosis, also known as desmoid tumors. My name is Matt Yergelin, and I'm a GI medical oncologist at the Dana-Farber Cancer Institute in Boston, Massachusetts. To discuss this complicated issue, I'm joined by two experts on desmoid tumors, Dr. James Church, a colorectal surgeon, and Dr. Dale Shepard, a medical oncologist, both from the Cleveland Clinic. Drs. Church and Shepard, thanks so much for joining us today. Would you please introduce yourselves to our listeners?
Hello, everyone. This is James Church speaking. I'm a native New Zealander, born in Wellington and raised in Auckland. I went to medical school in Auckland and did my surgical training there before coming to Cleveland in 1983 for a fellowship in colorectal surgery. What was originally intended as a one-year experience turned into a career, and I came on staff at the clinic in 1989. I took over responsibility for the polyposis registry that had been started 10 years earlier by David Jagelman. Jagelman was an English surgeon who had just moved to the Cleveland Clinic in Florida when I arrived. I've been leader of this registry, more recently known as the Weiss Center, until my retirement in 2017. I'm now a consultant in the same department, but practice full-time in the way that I have for all these years.
Hello, this is Dale Shepard. I'm a medical oncologist here at Cleveland Clinic. I initially earned a PhD in pharmacology, then completed medical school, my medicine residency, and a hem-onc fellowship here at Cleveland Clinic. I've been a staff oncologist since 2009. I oversee the early phase drug trial program and the sarcoma program here at the Taussig Cancer Institute. I'm one of two medical oncologists who treat desmoid tumors.
Wonderful. Let's start off with some background. Dr. Shepard, can you tell us what are desmoid tumors? Are they cancers?
So desmoid tumors are rare tumors, fewer than 5 cases for every million people. The biologic basis for the development of desmoid tumors is not clearly defined, but a cell signaling pathway called Wnt or beta-catenin is thought to play an important role. A gene called APC is known to be associated with the development of desmoid tumors. Alterations in the APC gene are associated with changes in the Wnt and beta-catenin in patients with desmoid tumors that are associated with FAP, which Dr. Church will discuss next, and sporadic desmoid tumors. Desmoid tumors can develop anywhere in the body, extremities, the abdominal wall, or as an intra-abdominal mass. Patients with FAP usually have intra-abdominal desmoids. As an oncologist, one of the most frequent questions from patients is this a cancer? A traditional cancer is a collection of cells that grow in an uncontrolled way that invade other tissues and spread to other parts of the body. So desmoid tumors, which are usually driven by genetic or signaling pathway disruptions that we just discussed, well, in that way, they are a cancer. But different from a traditional cancer, desmoid tumors can compress but don't invade nearby tissues or organs, and they don't metastasize or spread to other parts of the body. Primary risk factor for desmoid tumor is FAP, but pregnancy and prior trauma can also be risk factors.
And Dr. Church, can you tell us a little bit more about the link between FAP and desmoid tumors? With so much else that our FAP patients need to worry about, how serious of an issue are desmoids if they're technically not invasive cancers?
Well, about 30% of patients with FAP develop desmoid disease, which I use to refer to patients with desmoid tumors, and a flat sheet-like lesion that is often found in these patients. It's not a mass, but it does cause issues by distorting, puckering, and disturbing the tissues around the sheet-like lesion. So we'll talk more about that later. But in FAP in general, the risk of desmoid tumors is based on gender, where women are more likely to get desmoids than men, the site of the pathogenic variant in APC, the clinical expression of the mutation, and in particular the presence of extra-colonic manifestations associated with Gardner's syndrome, and a family history of desmoids. In fact, the strongest risk factor is the family history of desmoid. So if somebody with FAP has a parent or a brother or sister with desmoids, then it puts them at very high risk if they have the disease of getting a desmoid themselves. About half of desmoid disease in patients with FAP is intra-abdominal, where it typically involves the mesentery of the small bowel and the retroperitoneum. And just under half of FAP patients get desmoids in the abdominal wall. There's a strong connection between desmoid disease and surgery, in that 80% of FAP patients who get desmoid disease develop the manifestations of it within 2 to 4 years of an abdominal surgery. In particular, it seems as if the construction of an ileal pouch is particularly likely to lead to desmoid formation. We have developed a staging system for desmoid disease based on desmoid size, its growth pattern, and the symptoms it causes. Stage 4 desmoids, that's 4 out of 4, is the worst stage with rapidly growing tumors, bad symptoms, and a poor outcome. Desmoid disease is definitely related to mortality, and in fact, desmoid disease is the second most common cause of death in patients with FAP. It's been this ever since data has been kept.
So these are certainly serious issues for our FAP patients. And Dr. Church, how should we be looking for desmoids and desmoid disease within our FAP patients? Are there specific symptoms to watch for? Should we be screening FAP patients for desmoid disease in the absence of symptoms?
Well, we definitely should be considering desmoid risk in every patient with FAP, and in particular those who are about to have a colectomy or some other form of abdominal surgery. Because, as we just mentioned, surgery is a strong risk factor for the development of the desmoid. It's as if the patients have the tendency and it needs surgery to make that an actuality. So patients that are in the preoperative period, we should think about desmoid risk in all of those patients. In fact, we've published a desmoid risk factor score based on gender, extra-colonic manifestations, family history of desmoids, and genotype. While a lot of the literature suggests that 3' mutations in APC are associated with desmoid disease, we've shown that mutations anywhere in the gene can be associated with desmoids. The 3' mutations, however, are associated with more severe disease with a higher clinical profile that makes it seem that desmoids are more common with mutations there. They're not more common, they're just more severe. Most patients with symptomatic desmoid disease present with a mass that is noticeable or painful, or with the effects of the disease on adjacent organs, such as a bowel obstruction or ureteric obstruction. Occasionally, desmoids can erode into the bowel, causing an abscess or a fistula, and we've seen 4 cases of a superior mesenteric artery aneurysm that has ruptured, the aneurysm being related to the desmoids that are surrounding the artery. These are often lethal cases. However, fully half of our patients with intra-abdominal desmoid disease don't have any symptoms at all, and we've paid particular attention to these by looking for them anytime we do an operation on a patient or get a CT scan on a patient for other reasons. In terms of screening, that implies getting a CT scan on every patient with FAP, whether they have symptoms or not. And really that's not justified because asymptomatic desmoids are not particularly our concern. It's the symptomatic desmoids that we're concerned about.
And Dr. Shepard, what is the appropriate radiologic and histologic workup for an FAP patient who is found to have a suspected desmoid tumor?
So desmoid tumors are initially diagnosed and followed radiographically by CT scans or MRI. CT scans are generally adequate for assessing intra-abdominal desmoid tumors. An MRI of a desmoid tumor in the extremities allows for better determination of involvement or proximity of the tumor to skin, nerves, and the vasculature in order to anticipate the effects of the growth of that tumor. This is important for determining the appropriate intensity of systemic therapy or the risks and benefits from local therapies like cryoablation. Given the lack of characteristic radiographic appearance of desmoid tumors and the lack of biomarkers to help guide a diagnosis, I try to obtain a biopsy on any patient who will be giving a systemic therapy. These are generally young patients who will be on therapy for a long period of time. A biopsy confirms that they have a desmoid tumor and rules out a cancer that would be treated in a much different way. This includes patients with FAP and an apparent desmoid tumor. As one of our Cleveland Clinic pathologists will often point out, a dog can have ticks and fleas. I have several patients who have more than one primary cancer. If I'm going to be giving a patient a treatment with toxicity, I should know what I'm treating and treat the appropriate disease. Histologically, a desmoid tumor will have a spindle cell appearance with monoclonal proliferation of fibroblasts and fibrous stroma. As these are usually slow growing, the cells will generally have a low mitotic rate and no necrosis. Most desmoid tumors will stain positive for nuclear beta-catenin, but this is not specific for desmoid tumors and is not necessary for the diagnosis.
Are there particular molecular features that are identified in desmoids, and are these different in FAP-related desmoids versus sporadic desmoids?
So when we think about the diagnosis of desmoid tumors, there are not molecular features that are typically examined to differentiate an FAP-associated or a sporadic desmoid. The difference is really more apparent from the patient's clinical history and the location of the tumor. At this point, the distinction is not necessary for determining the appropriate therapy since we don't have a different therapy for a desmoid tumor from either type.
So, Dr. Church, if we identify a young adult FAP patient with a small and asymptomatic mesenteric desmoid after their proctocolectomy, given some of the concerns and complications you mentioned, I assume we should be sending them straight to one of our surgical oncologists for prompt surgical resection. Is that correct?
Well, basically, no. This sounds like a stage 1 disease, which we define as less than 10 centimeters in diameter, not growing, and asymptomatic. So these don't need active treatment. And it makes me wonder why the patient had the scan in the first place.
So let's say it was maybe an overly enthusiastic practitioner who hadn't yet listened to this podcast to know that we don't necessarily need to be actively screening our asymptomatic FAP patients for early desmoid disease. So with a stage 1 desmoid tumor, observation alone is an appropriate therapy. Is that correct?
Definitely. If we want to treat it with something, then we would use Sulindac, 150 to 200 milligrams twice a day with food. In the data that is available on Sulindac, it does have an effect on desmoid tumors, but it's a slow-acting effect that may take at least a couple of years to manifest itself. The advantage of Sulindac, though, is that if there's any residual large bowel mucosa somewhere in the body, it will suppress polyp formation there, so you get 2 for the price of 1. And in general, we've been very liberal at using Sulindac in any patients that's been shown to have a desmoid tendency.
And so for the larger, more symptomatic desmoids, where surgical resection or surgical management is being considered, can you speak about the type of surgeries that tend to be required for FAP-related desmoid disease, and what are some of the short and long-term risks of these surgeries?
Perhaps the simplest desmoids to deal with are those that occur in the abdominal wall. These can be small, but they can be very big. And they're symptomatic because they're towards the outside of the body. Patients notice them. Typically, patients will be unable to lie on their tummy because of the hard mass that's in their rectus muscle or their abdominal wall muscles. So our philosophy about managing these is to resect them as soon as they're discovered. The resection tends to be simple because you're just cutting out a piece of the abdominal wall, which you then repair with a mesh. Sometimes the desmoid goes into the abdomen a little bit, and sometimes a loop of bowel is stuck on the inside of it. So you have to be careful and be looking for that and be prepared to deal with it. But it's generally not worth treating these abdominal wall lesions with any form of chemotherapy because they can be so easily resected. Intra-abdominal disease is another kettle of fish. Most intra-abdominal desmoids grow in and around the mesentery of the small bowel and intimately involved with arteries and veins supplying the small bowel. You cannot dissect desmoids away from these sort of tissues, and so resection of the desmoids involves resection of the mesentery and therefore loss of bowel. The closer to the base of the mesentery, the more sizable the arteries and the more bowel is lost. And patients can lose so much bowel that they need intravenous feeding for the rest of their lives. In fact, there have been some reports of small bowel transplant as an intentional treatment for aggressive or symptomatic or rapidly growing mesenteric desmoid disease. Sometimes you get lucky and intra-abdominal desmoids grow close to the bowel, so at the edge of the mesentery, and these can be resected with a wedge of bowel that is not a major threat to the patient's quality of life. However, resection of intra-abdominal desmoids is relatively uncommon. Most of the surgeries that I do for patients with desmoid disease are for the complications of desmoid disease on other nearby organs, such as to relieve a bowel obstruction or to fix a fistula or to deal with ureteric obstruction. I don't do those operations, but those are the surgeries that are done. This sort of surgery is done using a combination of techniques which are aimed at dealing with the complication while not necessarily resecting the desmoid. It certainly helps if the desmoid is smaller rather than larger, and so oftentimes we'll use Dr. Shepard and chemotherapy or other treatments that he's going to be telling us about to see if we can shrink the desmoids before we operate on them. I think that's a help. But these are tricky surgeries that are a little scary because the stakes are high and it's easy for bad things to happen. But these patients need the help and need to be treated.
Are FAP-related desmoids at risk for recurrence after successful surgical resection?
Yes, desmoids have a very bad reputation in terms of local recurrence after resection. In our patients with intra-abdominal desmoids, recurrence rates are about 50%. That's not bad because in the literature, the recurrence rates are up to 80% in other series. Abdominal wall desmoids recur less commonly, but in our series, the rate is still 35%. These high recurrence rates aren't surprising, though, because desmoids are tumors of scar tissue, and they're stimulated by surgery. So when we do surgery to treat them, we might expect more desmoids to form. And so it's not a surprise.
Should we be concerned if our patient who has a resected desmoid has a microscopically positive margin at the time of surgical resection?
Well, there aren't much data out there to address this point, although when we studied our data, we showed that for both abdominal wall and intra-abdominal desmoids, we felt completely resected. An R1 resection, that is a microscopically positive margin, had the same recurrence rate as an R0 resection, which is a histologically negative margin. However, determining margins is challenging for the pathologist because desmoid disease, as Dr. Shepard described, is proliferation of fibroblasts, and the transition from a scar to a desmoid is oftentimes not particularly easy to define. So we usually go 1 centimeter around the desmoid. We look for a margin of that extent, and as I said, our data show that if it's microscopically involved, recurrence rate is no worse.
And so, Dr. Shepard, are there instances where you might consider non-surgical therapies for a desmoid tumor, even if it is felt to be anatomically or radiographically potentially resectable?
The most common non-surgical approach to potentially resectable disease has been cryoablation by our colleagues in interventional radiology. For example, a recent patient had a large paraspinal desmoid tumor that was causing pain and limiting their range of motion. And so while potentially surgically resectable, this would have been associated with significant morbidity and a prolonged recovery, and this is in a setting where it's likely to recur anyway. And so systemic therapy may decrease the size of the tumor, but the response rates are relatively low. As Dr. Church just mentioned, sometimes those responses are very slow to develop, and that time to response can be a significant factor. This particular patient had cryotherapy with a radiographically complete response and was quickly back to work and has still yet not had a recurrence. If there is a recurrence, then this can be managed with conservative therapies. The most common use of radiation is for palliation of symptoms in tumors that are not resectable or when a more rapid response is required.
And Dr. Church, what sorts of features would lead a desmoid tumor to being deemed unresectable?
The most common reason for not being able to resect a desmoid in patients with FAP is involvement of the mesentery of the small bowel in the way that we have described. On the scans, desmoid tumors often look like a softball or a baseball or even a basketball, but they're not as well defined as that. And often desmoid disease spreads its tentacles out to the surrounding tissues and becomes integrated with them in a way that really makes it impossible to just cut around it and lift it out. That's pretty uncommon. So it's the way that these tumors spread into surrounding tissues and involve themselves with organs that you cannot resect, such as the aorta or the ureter or the kidney or the arteries going to the small bowel. Resectability is also a subjective assessment by the surgeon, and many surgeons are understandably hesitant to approach a patient with desmoid disease, especially if they don't see it very often. Desmoid patients have very bad adhesions in general terms, and so doing an abdominal surgery in a patient that has desmoid disease is time-consuming and tricky, and it's always possible to damage the bowel just from the severe adhesions. It's easy when operating on desmoid patients to make the situation worse, which is something that as physicians we try not to do. However, it is a shame when patients are denied surgery that could fix an issue because surgeons are reluctant to try. And this is where the role of doctors who specialize in desmoid disease can be helpful. So many patients can be helped by a judicious surgery, not necessarily resection. As I said already, most of the surgeries I do are not resection of desmoids, or they may be partial resection of desmoids, but they're trying to deal with the complications of desmoid disease. And if a tumor is resectable in that I can get around it and take it out intact without damaging anything else, it makes my day.
And Dr. Shepard, for desmoid tumors that are unresectable or where surgical management is not appropriate, when do you consider systemic therapy, and what sorts of systemic therapies have activity in desmoid disease?
Well, I guess I'll start by pointing out that surveillance, just observation, is always a good option in patients who have previously stable and asymptomatic tumors. Interestingly, in a recent phase 3 trial that we're going to discuss in a minute, about 20% of the patients in the placebo or the untreated arm had a decrease in the size of their tumor. So primary indications for starting a systemic therapy are growth of the tumor and development of symptoms. The appropriate systemic therapy is dependent upon how quickly a response is required. So patients with minimal symptoms and a tumor that is growing slowly, I generally start treatment with either single-agent Sulindac, which is a non-steroidal anti-inflammatory, or Sulindac in combination with raloxifene, which is a selective estrogen receptor modulator. So depending on the severity of their symptoms and the need to get control of their tumor, that would be the primary starting point. It's important to realize that it can take weeks to months, or as Dr. Church mentioned, even for an optimal response, a year or more to get that optimal response. So realizing the need to get control of the tumor is important. Patients remain on these therapies as long as they're tolerating them and as long as the therapy is controlling the tumor growth. Patients with more rapidly growing tumors or with symptoms that need better control will receive drugs called tyrosine kinase inhibitors. Recent clinical trials have shown that 2 of these drugs, specifically pazopanib and sorafenib, are effective in patients with desmoid tumors. So, for example, pazopanib was compared with chemotherapy, and over 80% of the patients had their tumors shrink. So, unfortunately, unlike Sulindac and raloxifene, which have very minimal side effects, these drugs like pazopanib and sorafenib can lower immunity, cause fatigue and diarrhea. They can affect the function of the liver, and particularly with sorafenib can cause a significant rash. So This is the reason to sort of determine the extent of control of tumor that's necessary to balance the benefits with the risks. Chemotherapy is generally reserved for patients who have very symptomatic disease or who really need a rapid response to therapy.
And when you talk about systemic chemotherapy or cytotoxic chemotherapy, are there certain chemotherapeutic agents that are considered?
So probably the most common that we would start with would be a chemotherapy called Doxil, which is a traditional cytotoxic chemotherapy.
And I know you mentioned NSAIDs and you mentioned raloxifene, which is a close cousin of tamoxifen. These are drugs that we sometimes use in other settings for some sort of chemoprevention. Are there any data about using these agents to prevent desmoid disease in FAP patients, especially since our FAP patients might be on Sulindac or other NSAIDs for management of their polyp burden, as Dr. Church alluded to earlier?
So chemoprevention has not been promising for most solid tumors, and dare I say the term really suggests something that's not likely possible. So for most cancers, we can do things that might minimize the risk of developing a tumor, but we can rarely prevent the growth. The best advice that I can give is regular follow-up for patients with FAP, and Dr. Church had mentioned that previously. And any patient who has an abnormal growth on their extremity, their trunk, their abdominal wall should really be evaluated by a physician sooner than later so that we can determine the best steps for treatment at an earliest stage possible. Our best tolerated conservative therapies are far more effective at stabilizing or slightly shrinking desmoid tumors. So the smaller the tumor is when we start that monitoring or treating, the better.
And Dr. Shepard, can you comment on any novel or emerging therapies that are being used to treat patients with desmoid disease? I know immunotherapy has become a very hot topic in the medical management of all sorts of different cancers and neoplasms.
Yeah, so immunotherapies certainly have become very, very popular, and patients will routinely come in and request them. But these drugs have been approved for many, many cancer types, but not specifically for desmoid tumors. There's an ongoing clinical trial of two different immunotherapies, a drug called nivolumab and ipilimumab, in patients with rare tumors. And in that trial, which is a national trial, there is a cohort for patients with desmoid tumors. This trial is ongoing, and the benefit is still not known. And so until we know that there's a benefit, I encourage everyone to use therapies that we know have an effect on tumor growth. Unfortunately, there are few clinical trials for patients with most rare tumors, and desmoid tumors are no exception. There is only one ongoing phase 3 trial for patients with desmoid tumors in the United States at this point, and that trial is with a drug called nirogacestat, which is being compared with placebo. There's a good response rate in the earlier clinical trials, and so we're hoping that this will continue to be the case in the larger study.
Is there a sense as to how nirogacestat works to potentially treat these desmoids? Do we know much about the mechanism of action?
So this drug is it's an inhibitor of something called gamma secretase. The phase 3 trial is based on a small trial with 17 patients, was reported. All these patients had progressive desmoid tumors. In that trial, 30% of the patients had a response, a partial response to therapy, so their tumor grew by at least 30%. And there was an additional 30% of those patients that had stable disease, and it appeared as though those responses had been pretty durable or long-acting. So hopefully we'll have some new therapies available soon.
Wonderful. Well, Dr. Church, Dr. Shepard, this has been a fantastic discussion on an important and complex and often confusing topic for our FAP patients and providers. On behalf of the CGA, on behalf of our listeners, I want to thank you both so much for your time and for your expertise.
You're quite welcome. It's been a pleasure. Thank you for doing it.
Yep, thank you.